Hi, my name is Derek Angus from the University of Pittsburgh, Pittsburgh in the US, and today I'd like to speak to you about the question of how we move ourselves as doctors to do the right things at the bedside. Or put another way, how might we think about nudging doctors? Here's my disclosure slide. What's the problem we're talking about? The problem here is that despite all our training and our best interests, we as physicians can sometimes not quite do the right thing. When it comes to diagnosis, we might fail to order the right test or order too many tests. We might admit the wrong patients. We might not triage properly. We may not prescribe the right treatment, giving the wrong antibiotics, or we may not even adjust devices such as the ventilator properly. When one thinks at the system level about how we try to promote better physician decision-making, it's typically based on something called the Fishbein-Aschen model of knowledge, attitude, and behavior. So what we're trying to do here is we're trying to get the physician to behave differently, and it's based on a model of thinking that the way in which we execute our behaviors is first of all based on our knowledge, followed by our attitudes. You can see in this slide, therefore, that the way that we've traditionally thought about how we end up making a choice or a decision, we would evaluate the patient. As we evaluate the patient, we have in our mind some background attitudes, opinions about various treatment options based on how well we know the literature. Then we acquire knowledge or decide in how much do we think this particular patient might have the condition of interest. And then when we move forward to then make a decision, we're going to execute some judgment that leads to our choice, but that could also be influenced by some barriers, external factors, and so forth. This is the mental model that social scientists have used forever in this so-called KAB model. The problem with this is that it's not quite right. A key threat to all of this is that it assumes that armed with perfect knowledge, we would be entirely rational. But rationality has its boundaries. We rarely, in fact, have perfect knowledge, and so it doesn't actually inform how decisions are made in the real world. Instead, decisions in the real world are influenced by time, knowledge, and information, all of which are limited, and so we try to make the best possible decision. In fact, the Nobel Prize winner Herbert Simon said, behavior is shaped like scissors whose two blades are the structure of the task environment and the computational capabilities of the actor, in this case, the doctor. And that actually led to bounded rationality, which got the 1978 Nobel Prize in economics. Let me boil it down to this. What we end up doing, because we don't have perfect knowledge, is we eyeball it. And this is taken from Sully's famous landing of this airplane on the banks in the Hudson outside Manhattan. This has been further expounded into a general way of thinking that the brain actually has system 2, rule-based deductions, which is everything I spoke about before, but also system 1, heuristics, our eyeballing techniques, our snap judgments. And this is a picture of Daniel Kahneman. This is sometimes described as thinking fast and slow. And why do we need to think fast? Well, we need to think fast. We need to have heuristics because sometimes we might, in the past, be going out looking for lunch only to find that lunch might be thinking that lunch is going to attack us. So let me give you an example. Imagine Linda is a 31-year-old, single, outspoken, and bright person who majored in philosophy, and as a student was deeply concerned about discrimination and social justice and participated in anti-nuclear demonstrations. What's more likely, that she's a bank teller or that she's a bank teller and active in the feminist movement? Many of us will choose B instinctually because this background sounds like she's a feminist. And in so doing, we would execute the conjunction fallacy. It is impossible for B to be more probable than A. This is what happens when we execute something called the representativeness heuristic, where we end up accidentally trying to choose something that is actually the intersection of these two circles, even though the question was which is more likely, which is mathematically impossible. And it turns out that there's many of these biases. That was representativeness, availability bias, where you're more influenced by something that just happened. When someone offers a number in a gamble, you're affected by the number you first heard, the affect bias, hindsight, and so on. Many different biases. One of the reasons we have these biases is because it's useful when we make a snap judgment to err in a particular direction. So if you're judging how quickly the mammoth is coming towards you, you will consistently tend to overestimate how fast he's approaching, even if that means that you might then decide to turn and run, even though you might have been safe after all. Because if you turn and run, you live for another day. If you estimate on the other side incorrectly, then it might be good night. And it turns out this is hardwired. These behaviors actually are driven by changes in neurotransmitters in the brain, such that in this experiment, when given a series of problems in an MRI scanner, healthy volunteers, even not using fear, in a perfectly rational, non-emotional way, would turn on dopamine systems when they were anticipating gains and turn off those systems when anticipating losses. And the interesting thing is that there was a steeper slope with loss. You felt worse about losing something than you did feel good about gaining something. And this was highly correlated. Risky people were more likely to have a different set point on their dopamine. So when we turn this to doctors, we find that, for example, if we take a simple decision such as if you see a patient in a small hospital with trauma, in the United States, we have a trauma referral system where everyone has been educated to say that certain kinds of patients should be sent on to a level 1 trauma center. And yet nearly half of severely injured patients are not sent on to the big trauma center. And what happens is you see a situation like this, where on the left you see a gunshot wound and you totally send that to the transfer center. You see an elderly lady with some rib fractures and you say, oh, we think we can manage this person here. They have identical injury severity scores and they should both have been sent to a trauma center. But one of them fits with our representative bias of what feels like a trauma case, and we always send them on. The non-representative case, we exercise a biased judgment. So how do we overcome this? Well, we could let the physician not make the decision, like autonomous cars, removing the decisions for driving the car from the driver. We could also try to exploit or manipulate the nudge, switching the default, playing with choice architecture. Or we could try to recalibrate our heuristics to take maximum advantage of the human potential, to have every doctor be like the airline pilot Sully. The problem is that's actually quite hard to do. Daniel Kahneman, the Nobel Prize laureate, said recently is that it's actually very hard to change heuristics. He had studied them his whole life. He would love to change heuristics. He admits it's hard to change even his own. So how do you change heuristics? Well, you basically have to change your background experience. You have to be reset in a sort of an accelerated way so that your biases get reset such that they're more likely to trigger the way we want. And so one way to do that is so-called serious games, where you actually get people to play video games that gives them a new experience and resets their set point so that they behave differently. And so we've been working in this space. We've now done a couple of trials. This work has been totally led by Deepika Mohan and very much with Baruch Fishoff on the right here, who was actually a postdoc of the Nobel Prize winner, Daniel Kahneman, and who is the person that discovered hindsight bias. So we've done a couple of RCTs now with emergency medicine physicians, where we would take several hundred physicians and randomize them to either being fully trained in the standard way for how to take care of trauma patients going through ATLS certification, etc., or have them play a game. This is a narrative game where they're learning about someone who goes to work every day, and there's actually a bit of a mystery in the background when they're hunting for their long-lost father and so on. But along the way, they're getting programmed over and over again to make the right decisions about patients they might normally not have done. So what we were trying to do with this game was associate action with consequence and encourage correct engagement through emotion, cognitive challenge, and role-playing, not just through teaching people things, but rather deliberately engaging those deep parts of the brain. And the bottom line was we had a big effect in the game versus educational program on making smarter decisions about referring patients. And not only that, even 6 months later, when we retested people, they were much more likely to know which patients should be referred and which patients should not be referred. And furthermore, all the improvement was improvement in the non-representative cases. In other words, the game was no better than teaching people around things like gunshot wounds because everyone knew what to do, but all the gains were around these tricky or atypical cases. We've now done a follow-up RCT where we again demonstrated improvement, and this time we actually chose a different kind of game because not everyone likes to do these narrative games. Some people would prefer to be taught through puzzles because they're more engaged by puzzles. The point here is that you can retrain with this so-called serious game to retrain the human mind so that its biases are more oriented towards the desired behaviors. So in conclusion, we are not rational actors. We seek to be frugal in terms of risk or loss aversion because for thousands, if not 10,000 of years, all our ancestors have been trained to be loss averse, which is an ongoing bias. And we seek to be efficient. We rely on these mental models when we make snap judgments. These innate characteristics make us susceptible to bias. Most healthcare behavior modification essentially ignores these biases and relies on the Fishbein, Ashton, Cab model. That is very good for understanding things like chronic behavior, like whether you would give up smoking or not. But it's not really designed for overcoming cognitive biases in the middle of snap, short-term, acute decision-making, such as something we face all day long in the ICU. Applying behavioral economics to ICU decision-making can give us insight into behavior and can provide opportunities to improve care. With that, thank you very much.